Welcome, everybody. Welcome to another episode of PEM Rules, the Pediatric Emergency Medicine podcast. I'm your host, Yaron Ivan, as usual, and today we're discussing some more important rules in the clinical care category. Rule number 79. Musculoskeletal chief complaint does not equal X-ray now. So this is a rule I try to practice in my daily life every day in the ER, and I would add to that rule that testicular pain doesn't necessarily equal ultrasound now. I'd like to, obviously, as usual, give you some examples. So many times I come into the ER and there's a patient whose chief complaint is testicular pain, which always makes us worry. We always worry about testicular torsion, which is a surgical emergency, which has some significant ramifications if not diagnosed early. But many times when I go into the room, the child seems very relaxed, not in significant amount of pain. When I take the history, I learn that it has been a day or two and the child has not been vomiting, the pain is well controlled. And in addition, I do a physical exam and it's completely reassuring and normal. The testicle is not swollen, there is good cremasteric reflex, the pain is mild at best. Usually under those circumstances, I tell the parents, Mom and Dad, when a patient presents with testicular pain, we worry that there's something called testicular torsion. That is a surgical emergency and that needs to be dealt with surgically very, very soon. However, your son has had pain for 2 or 3 days, which really is inconsistent with that diagnosis. His exam is also very reassuring. The testicle is not swollen, he's not vomiting, which usually those patients are, so I don't think there's testicular torsion. Now, the reason I say that to the parents and to the patient is because, from my standpoint, if the child is not a teenager, any other thing that will cause testicular pain, to the best of my knowledge, is benign and the treatment will be NSAIDs and a follow-up. Orchitis, torsion of the appendix testes, maybe epididymitis that in a non-sexually active child is treated with NSAIDs, so I don't feel the patient has to have an ultrasound today. If I get a teenager that the pain is significant and there's any sort of swelling and the pain is acute, surely testicular torsion needs to be ruled out. But I don't feel that testicular ultrasound is indicated every time the chief complaint is pain in the testicle. Testicular torsion is very rare in school-age children, and usually the exam makes it very clear. So if the child is not the right age, the exam is reassuring, I know that most likely all I will find is some benign diagnosis that I'm going to treat with NSAIDs anyways. I share that thought process with the parents, and I don't necessarily get an ultrasound every time there is testicular pain. It depends on the age, it depends on the presentation, etc. Of course, as usual, I give very good anticipatory guidance and make sure, number one, that the parents are not worried, and if they are, get an ultrasound, no big deal. And I make sure the parents know exactly what to watch for and what to come back for, and of course, document that. At the same time, going back to the first part of the rule, musculoskeletal chief complaint does not equal X-ray now. I think it's very important to keep in mind. On X-ray, you can only see bones. And if I do not suspect this child has a fracture, X-ray is not indicated. A good example will be an older child. Remember, kids with open growth plate fracture very easily. But an older child with a very mild injury, with no swelling, minimal tenderness, etc., probably has a soft tissue injury and nothing else. If I don't think the bone is broken, there is no need for an X-ray. Rule number 79 that says musculoskeletal chief complaint does not equal X-ray now and testicular pain does not equal ultrasound now relates to 2 other rules we've spoken before, namely rule number 4, less is more, which we keep getting back to, as well as rule number 36 that we discussed in episode 9, don't do something because you can, do it because the child actually needs it. A child with a mild injury with no swelling at the right age probably did not break a bone and there's no reason for an X-ray. A 4-year-old who's complaining of testicular pain, has no swelling, reassuring exam, the testicle is not particularly tender, he's not vomiting, and it has been a few days, doesn't have to have an ultrasound now because the chance you'll find torsion is very, very small. Again, good anticipatory guidance and making sure the parents are comfortable with the decision to go home. Rule number 80. Perfect practice makes perfect. I would like to thank my friend and resident Vlad, who introduced me to this rule. He's one of our senior residents in the emergency medicine residency program. A great guy. He taught me this rule and told me about it when we were working one day, and this is taken from his career as a wrestler when he used to practice wrestling, compete, and even coach. And Vlad said that to become the best at something, to really master it, you have to study it, and you have to practice it, and you have to practice it meticulously. For the most part, the way you practice something is the way you're actually going to perform it when it really counts. And I can tell you from my military service, that is very, very true. The way you practice something is the way you're actually going to do it when you're under pressure. It's going to come like second nature. When you practice something, it's not just the amount of hours you put into the craft, it's how you spend them. It can be easy to just run through the motions if you did not pay attention to every small detail, if you did not make it look and make it feel as perfect as it's supposed to, then you're really just reinforcing the wrong thing and the wrong technique. That specifically plays a role in procedures you perform. It does not matter if you are absolutely fresh and energized or completely wiped out at the end of your shift. You have to practice it the right way, the same way every time. Shout out to rule number 20. That is when mastery is really achieved, and that is when it becomes second nature. And that is when you begin to make it look easy and natural. So perfect practice makes perfect. If you fail, it is also important to take a step back and reassess what needs to change. What am I not addressing? What am I doing wrong? Why am I not getting it? If you miss something this time around, what can you change to make it better the next time? If you're not sure, ask someone, a mentor, a more experienced provider, etc. This is what training is all about. So perfect practice makes perfect. Drill the procedure right, the workup for this chief complaint right, the outline of your presentation to your consultant right. It is okay to be a bit obsessed about it, be critical of every detail, and do not deviate from the right steps. This is how you achieve mastery. Don't practice it the wrong way, because the way you practice it is the way you're actually going to perform it under the most pressure. You owe it to yourself to practice perfectly. Rule number 81. Remember, what seems like cause and effect can actually be just a red herring. This is something that comes into mind every once in a while when I see a kid with the chief complaint, and I learned later on that really the chief complaint or some details in the HPI were not at all relevant to the diagnosis, and I just got misled by some red herring. A good example is if you see a child who had, let's say, what seems like a very mild head injury, let's say 4 or 5 days ago, and he's coming in with new onset seizures. Sure, when a child sees after a head injury, we worry that there's a subdural, epidural, etc. But if you listen to the story and hear that it's been a few days, the trauma is sort of mild and the child was fine afterwards, it's very unlikely, and I think it's important to keep in mind that it's very unlikely this is a subdural or epidural. Maybe this is just new onset epilepsy and that head trauma was just a red herring. So remember, cause and effect can also be a red herring. I'd like to share a story that I heard from one of my another previous resident, who's now a PEM fellow in Texas. Her name is Lindsay, and she was one of our excellent pediatric residents. Loved working with her. Thank you, Lindsay, for this story. She recently saw a 2-year-old who was previously healthy in the pediatric emergency department. He presented in respiratory distress. According to mom, he was drinking milk at home and all of a sudden developed shortness of breath. EMS was called, and they reported the patient was hypoxic to 78%. They reported barky-like cough, and on the way to the hospital, gave him racemic epi, and they did report some improvement. Of note, the patient was discharged 2 days prior from the hospital after a 2-day admission for bronchiolitis. He required some high flow, but did well and went home. Mom reports that the cough and congestion had persistent, and he became short of breath shortly after he had a cup of milk in the afternoon. When he arrived in the emergency department, he was in severe respiratory distress with retraction, head bobbing, and abdominal breathing. He had a prolonged expiratory phase, and the patient was trialed on albuterol with minimal improvement. He received IV Decadron, IM epi, and a fluid bolus. Chest x-ray showed bronchial wall thickening, and he was started on BiPAP with some improvement. Certainly, one can blame bronchiolitis for this whole reason. Maybe it just got better and got worse again. Maybe he aspirated some milk, but as the story continues, I think this is a good example of thinking of red herring. Patient became sleepy, repeat blood tests showed worsening hypercapnia, he was intubated, And after the intubation, he improved a little bit and his oxygen requirement were only 30%. However, he began having coughing episodes while intubated with associated desaturation to 15% and became bradycardic with heart rate of 50. He received a code dose of epinephrine and responded before compressions were started. At some point, the respiratory viral panel returned positive for parainfluenza, and I think at this point, most people thought they had the answer. Unfortunately, the kid got another episode of bronchiolitis with the bad virus. He needs to stay intubated until he weans. They repeated chest x-ray, which showed continued bronchial wall thickening, which is very consistent with bronchiolitis. So again, everybody thought they had the answer. But he continued to be very labile on the ventilator. And the ventilator would intermittently alarm with high peak pressure, followed by declining tidal volumes. He required several additional doses of epinephrine to maintain heart rate more than 60. And once he was admitted to the PICU, the patient went into cardiac arrest and started on ECMO. The following day, the patient's chest x-ray started to show left upper lobe atelectasis and right lower lobe atelectasis. He was taken to the OR to have a bronchoscopy, and unfortunately was found to have a peanut in the trachea. I think this is a great example how the respiratory viral panel and the initial x-ray can just mislead you that this is just bad bronchiolitis. So remember, cause and effect can also be just a red herring. Yes, the RVP was positive. Yes, the chest x-ray looked like a viral illness, but usually kids with bronchiolitis don't do so poorly, especially when intubated and ventilated. Usually kids with bronchiolitis do not arrest so many times. I think this is a great example why you can remember that cause and effect can also be a red herring. That RVP, I think, misled everybody, and unfortunately things were not identified so quickly. So remember, cause and effect can also be just a red herring. And this is it for today, guys. Thank you very much for listening. I appreciate it. Please feel free to check pemrules.com, submit any feedback, ask any questions you want, and contact me anytime. I'd love to hear from you. Hope you have a great day. Stay safe out there. Bye-bye.